We're going to get started since we're a bit late. Once again, please accept my sincere apologies, especially to Dr. Morgan. My apologies for the tardiness here. Today is a great honor to have a colleague and friend join us for Internal Medicine Grand Rounds. Dr. Daniel Morgan is from the University of Maryland. He's a tenured professor of epidemiology and medicine at the University of Maryland. And it directs the Center for Innovation and Diagnostics, something we'll hear more about today, and is also chief of epidemiology at the VA Maryland Health System. It should be known that he was the founding member of, or the director of the Society for Healthcare Epidemiology of America, SHEA Research Network, and he's also been on the board of directors of SHEA. He's the incoming SHEA chair for the ID Week 2022, which is the National Infectious Diseases Conference. He also directs the VA Maryland Healthcare System epidemiology unit with a team of 5 physicians and 6 nurses. I'd like to mention that his research explores probability in medicine, medical overuse, diagnostic stewardship, and infection prevention. So it's not limited to infectious diseases and infection control. He's won an NIH New Innovator Award for exceptional scientists pursuing highly innovative approaches to major challenges. And he's exploring clinician risk understanding, which is a critically important message or issue at this time. He's also led to creating a website called Testingwisely.com. He's well-funded, federal funding, has over 170 publications, and his work often appears in the media, including New York Times, The Washington Post, and The Economist. It's a great honor and pleasure to have Dr. Daniel Morgan join us today for Internal Medicine Grand Rounds to discuss the title, Incorporating Probability into Diagnosis and Treatment. Thank you very much, Dan. Take it away, sir.
Great. Well, thank you for the flattering introduction, Gonzalo, and great to be able to talk with you and your colleagues at VCU again. Let's see, and just making certain everyone can see my screen share, correct? Okay, I will assume that is true. I always try to pause at the beginning to make certain that I'm not sort of talking without everyone else seeing what I'm talking about. And I'll say that VCU is really a great place. I've been impressed by the doctors who are there. I mean, I feel like personally, I know Dr. Behrman, Dahl, Stevens, Donnenberg, and a new member of your faculty, Sylvia Munoz-Price, and who are all like really distinguished people at a national level. And I think we're going to be sending a fellow down, Akira Shishido, who is also quite remarkable, and we expect great things from. So let me jump into disclosures. None really other than funding from federal agencies and conference organizations. And the biggest one is probably that I'm an ID doctor talking about general medicine. And so please have a little patience with me. I'm a big believer in general medicine. I find it to be the most compelling part of what we do. I like ID because it's more contained and easier, but I think general medicine is, what really matters to the population mostly. So let me start out with this story. So there are these 2 young fish swimming along, and they happen to meet an older fish swimming the other way, who nods at them and says, "Morning, boys, how's the water?" The 2 young fish swim on for a bit, and then eventually one of them looks at the other and goes, "What the hell is water?" And so the point of this fish story is merely that the most obvious important realities are often the ones that are hardest to see and talk about. And I took this story from David Foster Wallace. So it's not mine, but I think it relates very much to medicine. Some of the biggest realities are ones that we don't pay attention to, and it's often easy to get lost in the details. So let's talk a little bit about how we know what we know in medicine, because I think this relates to the topic that I want to really get into, which is medical probability. So epistemology is this mouthful of a word that I don't feel like I really understood despite a liberal arts education. But I think, listening to Adam Rodman's Bedside Rounds podcast and reading a book about how doctors think helped me with this. And it's really just how we know what we know in medicine, which is a really important question. If you think about it, like how do we know, which tests work or treatments work? Well, it may be more complicated than it's just simple, obviously, that they work. So I think the basis of how we know what we know, there's a lot of theoretical bases, and these are relevant, certainly. And let me highlight the ones that doctors scoff at more readily. Things like humoralism, the idea of 4 humors, which really dominated medicine for over 1,000 years. Even like in the age of Osler, there was talk about like it's good to bleed patients a little bit who have pneumonia. So humorism has had a huge impact and has been the dominant theory. And obviously wasn't a very clinically studied approach. And I still think it holds true with things like there are too many toxins, there are not enough vitamins or minerals that seem very common in people's mindset. Osteopathy, homeopathy are obviously mostly theory-based approaches. But I would include things like pathophysiological reasoning or anatomical reasoning, or even trying to apply like immunology or microbiology in my field of ID directly to clinical medicine and assume that the theory from those sciences will produce obvious correct answers when applied to patient care. And then modeling, during COVID-19, of course, this has been the primary form of evidence. Just throw it into a model and publish a preprint, and you have policy changing work. But really, this is largely theoretical. People, put in inputs that make sense into models and then get outputs, and it seems more like a concrete information rather than sort of like a computer-aided theory. So empiricism is what I'd argue is more important to medicine, is what's really led to better advances. And the most basic empiricism is things like observation and direct experience, what every clinician gets by seeing patients. Obviously, this is critical because it really hones our ability to understand what's happening with patients, but of course it's limited because we only can see so many patients. And there we have clinical studies that fill in a lot more. Things like observational studies, which, obviously like 99% of the studies that are out there, every study I've ever done, except for one, I believe, was observational. And then RCTs, which are much harder, but much more important for really understanding reality. And RCTs are primarily thought of as, does a test or treatment ever work? Not specifics beyond that, but just like, does it work? Yes, no. And I'd like to argue that they can give a lot more information, which is how much or how often does it work? In medical probability, thinking in terms of that paradigm allows us to better understand that. And I would argue that the way we practice medicine now doesn't use the evidence we have. It doesn't best use the evidence we have, and we could do better medicine if we actually just use the information we have through a different prism, through a different lens. And so that is probability, which is not a new idea. This is Osler, who is always quoted in talks and has a great quote about probability, that medicine is the science of uncertainty and an art of probability. This is over 100 years ago, and just in the past few years, you can still see editorials in the New England Journal of Medicine talking about conquering, accepting uncertainty and probability in medicine. So it's not a new idea, but it's one that we really have not been comfortable digesting or implementing into clinical practice. So how do we teach probability? I think what we currently do for medical students, I'm the person who teaches it here at Maryland, so I know I'm trying to revise our approach to it, but we give a few hours in medical school essentially as math equations. And for anyone, who has blocked this out of their brain because it felt kind of painful and complicated, this is the approach, the 2x2 table, the friend of epidemiologists, which I kind of hate 2x2 tables because I find them to be the least intuitive thing one can do. But so, we teach this approach to testing that we say, like, you have test or disease. Disease is the top test result on the left, and then you can find like false positives, false negatives, true negatives. And then you can work with the probability of that the patient has it to work out positive predictive value, negative predictive value. Similarly, with treatment, we are talking about the rate in the experimental subjects versus control subjects, and then looking at the absolute risk reduction, which, when you think about it in formulas like this, it still makes my head hurt to try to really remember exactly what we're talking about when we're actually talking about a pretty simple concept, which is, if you don't do something, how often do people have disease? If you do something, if you intervene in some way, does it change the chance of a disease outcome? And then I would say, this is from a cardiologist up at Penn State who argued that it's beaten out of students by clinical rotations. And I think it's hard to ignore this, that we teach this in first or second year, and then in third or fourth year, people never see it in practice. And it feels like it's, this kind of not useful kind of theoretical approach to medicine. When I would argue this is actually like one of the most important things in medicine if we could implement it better. So I would say medical probability is taught mostly by aphorisms. And so probably the most famous and I think best one is when you hear hoofbeats, think horses, not zebras, or the other way of saying this, common things are common. It's a great aphorism, it's a great thing to remember, but it's, far from actually having like a field of study or a science related to something. Some other things that are used and have been called pseudo-probabilistic aphorisms, like they sound like probability, but who knows what they really mean, is until proven otherwise, diagnosis of exclusion, high index of suspicion, low threshold, and even within a reasonable degree of medical probability. And so I'd argue, and what I hope to convince you during this talk, is probability is the basic science of clinical medicine. This really does tell us what works in clinical medicine and what we should be doing for our patients. But I think the problem is that pathophysiology is still the dominant paradigm, that we cram a lot of pathophysiology in the first 2 years of medical school, and that's really sort of how we talk about things still. If you listen to the news or something else, like it's all about the mechanism, it's all about the theoretical understanding and not sort of what's observed in real life. And I love Rudolph Virkle. He's a physician from the 1850s who did a lot to modernize medicine and move it away from humoral medicine. But he has this great quote about pathophysiology, which is remarkable for a few reasons. So let me read it. So medical practice is nothing but a minor offshoot of pathological physiology as developed in laboratories of animal experimentation. And to me, this is amazing, both that he said it in 1850s, when I think all of us would say, well, what do you know from animal laboratories? And that this really, I think, holds true to our approach largely now. And so what do I mean by medical probability? What I think is a better approach? Well, so when we're talking about medicine, in general, medicine does a lot for patients, even if it's not really based in science, right? For thousands of years, all different forms of medicine have been comforting people who are sick, providing them guidance, providing them some explanation of what's happening. And that's important, right? Whether you call it the placebo effect or, you explain it in some other way, disease and illness is terrifying, and having somebody to guide you through that process is really important. But in the US, in what we focus on is modern medicine. The real reason that we give such high esteem to medicine, that we sink so much money into it, is that we believe that it's something better than just comforting, right? We believe that through better diagnosis and better treatment, we will give patients better outcomes. And certainly this has happened at times, but I would argue that it could be better. And so when we talk about diagnosis, well, how are we supposed to make diagnosis? The evidence-based approach focuses on considering the pretest probability, so the probability of different diseases that would be based upon incidence, history, and physical exam, forming a pretest probability, and then testing when necessary to change that probability, and that you get these posterior probabilities, or the positive and negative predictive value. And Bayesian reasoning has become popular lately. People like to talk about their priors and how that changed with new information, but that's essentially what we're doing here with testing. And then getting to diagnosis, hopefully. And as many people, probably have seen this during training, that you have to tend to think about sort of what are your thresholds for doing things. And this is the idea that probability goes from 0 to 100%, pretty much never including 0 or 100. But that if something's very unlikely, you probably shouldn't be testing for it, because tests aren't perfect and you'll have these false positives that can lead to confusion. So it needs to be reasonably probable to test for something. And then if something's really probable, you probably shouldn't test for it, because you can miss it. You can have a false negative test and then be more confused when you should just be treating those patients. The problem is that these numbers are not you can't look them up in a textbook and you can't memorize them. It's much more of a concept. And I think that makes it harder to apply to real life. So, what do I mean by test? Well, information that makes a disease more or less likely. And so that can be blood tests, the most common thing we do, imaging, even the physical exam can be described in terms of the metrics that we think about for test. But I would argue that the way that we tend to think about tests is what during in one great article during the COVID-19 pandemic described as the magic test hypothesis. And that's essentially that tests are kind of magical, that there's no downside to doing them, and that they'll tell you exactly what's happening. And all you have to do is just not forget to get one, or not avoid getting one. And this idea, I feel like, is captured by Star Trek, and this is probably from the 60s or 70s, with Bones McCoy placing a probe over Spock and then getting a readout on the computer screen that tells him exactly what's happening. And if only medicine was this easy, like, it would be great, right? Like, you don't even touch the patient and you get perfect results, and then you know how to act. Whereas in reality, tests are useful, but they're far from perfect. That they make a positive make things more likely, and negative makes things less likely. But there's a lot of clinical thinking that needs to happen before and after that. So how should we think about testing? Well, what's the knowledge required to use a test? I mean, I'd argue that I think we've undervalued the complexity of testing and diagnosis. And we've seen movement towards acknowledging this with the diagnostic error in medicine and diagnostic excellence focus from the National Academy of Medicine and other groups. But I think that testing and diagnosis is more complicated than we give it credit for. So, that we need to know that a sample was collected or transported appropriately. We need to know how accurate is the machine that this test is being run on. And I would say this is often compared to other machines, and that we get this analytic sensitivity and specificity, which is the lab approach to quantifying how well a test works. And I would argue that this is not the sensitivity and specificity that people on this call should care about, because we're doctors seeing patients. We're not lab experts. And what we really want to know is what it means to patients. So what would tell us more about that is, how well does this compound or finding distinguish disease from not? Right? Because this is what we do when we see patients, that we're seeing people and we're trying to figure out, like, does this test help us confirm a diagnosis or rule it out? And that'd be thinking more in terms of probabilities. That this icon array image, I think, is helpful. And so this is a high sensitivity troponin test described this way, that it's 99% sensitive. So great sensitivity. It will pick up all cases of heart attack, pretty much. You may miss 1 in 100 or really less, but it's not that specific. There'll be 11% false positives. So for every 100 people tested, you'll have 11 that are positive, even though they don't have myocardial ischemia. And that's not too good, right? So a positive test doesn't mean that much, because you'll have a lot of false positives, but a negative test is quite good because you almost never miss it. So there is a term which is clinical or diagnostic sensitivity and specificity, which summarizes these three things. And so I think this is very useful. Like, if you can find for tests, like, what's the clinical sensitivity and specificity, is very useful, because then you can apply that to the patients you see. But that's not all we need to know for testing. And that's why it's hard to make good diagnoses. You have to think about the patient in front of you, which each patient is different. And to start out with, how likely are they to have disease? And then what's the meaning of a positive or negative test result in them? So say if there's a 16% pretest probability, positive test may make it go up to 70% and negative test down to 2%. And this is like a CT pulmonary embolism exam. So a test we do all the time, and it's good, but not great. Still there's a lot of uncertainty. So, I think testing is more complicated than we give it credit for, and it's because we'd have to accept the uncertainty that actually is present in a lot of medicine. And so the way that I really decided to delve into this project, I guess, this is why I got the NIH New Innovator Award, was trying to say, well, do we really do this in real life? There's been some studies where they tried to ask doctors basically math questions, where they'd say, like, here's sensitivity, specificity, pretest probability, what's the post-test probability? And to me, that doesn't really sound like medicine, right? And I think doctors were quick to dismiss it and say, like, I'm not a statistician. which you shouldn't be a statistician. I mean, I'm an epidemiologist and I work with statisticians all the time, and I'm certainly not. But we should be pretty good at knowing how likely somebody is to have disease. And and I'd argue that it's not really statistics. Like, it's kind of like basic intuition, which is really probability based. So we did a survey of over 500 clinicians across 8 US states, where we asked a series of pretty bread and butter questions, we thought, kind of boring medicine, but we wanted to get at, how well do people think in terms of probabilities with really simple things that they do every day. And so here's, one example of what we asked people. We said, does this patient have cardiac ischemia? And this is a 43-year-old premenopausal woman who presents with atypical chest pain and a normal ECG. She has no risk factors and normal vital signs and examination. So, shouldn't be that hard a case, right? This is not one that would be on your boards. This would be like, something for a medical student, a pretty straightforward case. But then we asked, so we asked how likely she have cardiac ischemia, and that may be a little bit harder. You certainly see clinicians sweat when trying to answer this, and myself included. And then we said, how likely is she to have ischemia after a positive or negative stress ECG test, which is the first line recommended treatment for outpatient ischemia. And here's what we found. So let me walk you through this graph. So this is the density plot. So on the vertical axis, you can see how many people answered. And then on the horizontal axis, you can see what they answered. So this is for how likely is she to have cardiac ischemia. And you can see if, a lot of people answered between 0 and about 20%. And the median was 10%. For the population for what the pretest probability is. But you can see some people actually were like estimating around 50%. So a fairly big range. And this yellow box shows what the estimate from the evidence, from scientific evidence. If you really took a lot of time and had a panel vote on what that was, which is the way we got it, which was 1 to 4%, with probably being on the low side. And then we said, okay, she has a positive stress ECG test. How likely is she to have cardiac ischemia? And this is where you really see some pretty dramatic results. So the median answer was 75%. So people thought she was 75% likely to have cardiac ischemia, although the evidence-based answer would be 2 to 11%. So a stress ECG is not a wonderful test, and according to cardiology guidelines, sensitivity and specificity is far from perfect. So it makes the probability more likely, but not a lot. But yet clinicians tended to really interpret this as being a very strong sign that she had cardiac ischemia. And then after a negative result, people change their probability down some, and so they weren't too bad at this. Like the green box is the correct answer, which is probably 0 to 1%. And the median answer after a negative test was 5%. So, not super far off, but, certainly the positive test results is where we saw, it was a striking disconnect. And we also asked this for UTI, mammograms, and pneumonia, and found very similar results. And this was published earlier this year in JAMA Internal Medicine. And just to emphasize, this is the difference. So, the standard answer from our participants, mostly at academic centers, was you have a positive stress test, it is 75% likely you have cardiac ischemia. Versus you had a positive stress test, it is 5% likely you have cardiac ischemia. To me, these are very different realities if I'm a patient, and very different realities about what should be done for this patient if I'm a clinician. And so I do think it's really important, this degree of difference, and and thinking about why clinicians aren't that good at estimating probability. Okay, so how does this compare to testing practice? Some other studies of testing that we've done. So we did a review of testing at hospital admission within the first 24 hours of admission. And this is on physician review, that it appeared that about 75% of tests had no benefits or harms. A small percent had harms, and only about a quarter of tests had some kind of impact on patient outcomes, some benefit on patient outcomes. And in this study, actually, we interviewed providers too. So the frontline providers who were taking care of the patients within the first 24 hours. And it was interesting to find out that they were unaware of about 40% of tests that had occurred. So there's so many tests that even the frontline providers aren't aware of many that are out there. So we do a lot of testing. And it's a new problem, right? 40 years ago, we just didn't do a lot of testing. It wasn't available, and we didn't have to have a better science for how to interpret them. And so, when I talk about harms of testing, like how could a test be harmful, right? Outside of like, having a hematoma from a blood draw or contrast reaction from a CT scan, the immediate harms aren't completely clear. But I think that the problem with tests is that they're information that we can't ignore once we've collected them. So here's an example of a case. So this is a middle-aged man with hypertension who had palpitations and chest pain. So the management he received, this sort of standard care, was he was seen by EMTs. He had tachycardia on exam. They diagnosed him as having SVT. They gave him adenosine, and he returned to regular rate and rhythm and was asymptomatic. He came into the ER, had a normal EKG, but there was some concern, like, let's just be safe and check a troponin. I should note that in a patient like this, the chance of having obstructive CAD is quite low. It's certainly under 4% and probably much lower if he's truly asymptomatic after this. But he had troponin checked. His troponin was elevated, which I would point out that a positive troponin still means that the predictive value is not that great. It's less than 25%. So even with a positive troponin, he probably doesn't have obstructive CAD, just because we know there's a lot of false positives with the high sensitivity troponin test. But this patient was recommended to have coronary catheterization to check for coronary artery disease. He had that. The good news is he had no coronary artery disease. The bad news is he had a RCA dissection. He had to get a stent placed and be on dual antiplatelet therapy and have an extended hospital stay. And I would argue that a more probability-based approach would be the same for the beginning, that he had tachycardia, he was symptomatic, he obviously needed some management, and he got that management, and it was actually highly effective. That he had adenosine and he was fixed. At least in the short term. He became asymptomatic and had no obvious problems after that. And so the probability-based approach would be to conclude this is likely SVT. This is unlikely to have some relationship to CAD in a patient without other symptoms or risk factors, and to discharge him home with follow-up with his PCP and not sort of go fishing for other potential problems. And I would argue that the difference is really important to patients. And like in this case, that by checking a troponin and having a positive one, that leads to anxiety and, the increased risk of false positives. And then by having a coronary catheterization, this patient actually experienced physical harm, extended hospital stay, cost, and then had to be on new medications for some time period, all with no benefit to him, right? So this was a case from JAMA Internal Medicine recently where they discussed it in more detail. But I think most clinicians have some stories that they remember of, like, gosh, I wish we wouldn't have done this thing. Or, I saw somebody who had an incidentalloma detected and we went down a pathway that led to them getting biopsy and having other problems. So, I don't think this is a rare example, but it's relatively rare that this is reported in the literature because, of course, no one is trying to highlight when things went bad. So I'd argue part of this is we need to go beyond first order thinking. And what do I mean? Well, first order thinking would be like, there's chest pain. What do? We do a troponin for chest pain. And this is obvious that for medical students, you have to think this way often because it's just, it's quite hard to really, memorize everything that, should be considered. And I'd argue that, us as clinicians, a lot of system one thinking, the psychological system one, these more innate, intuitive kind of quick responses, which is most of how we think in day-to-day life, is just kind of reactions like chest pain. All right, troponin, EKG, and, whatever the next test would be. But I would argue that patients are better off if we pause and think a little bit more in this sort of system 2 approach, or as hypothedeductive reasoning, where we'd say, okay, chest pain, what, do I think he has ischemia? And if I do think he has ischemia, how will a positive or negative test impact this patient? And certainly a lot of times it will be helpful, right? If you think, well, this is somebody we would treat differently. If they have a positive, I think it's relatively likely, well, you should do the test. But I think that the pause in thinking about this, especially, what will we do with the positive or negative, can lead to much better care for a patient. And so how can we do things differently, right? I've been trying to argue that a different approach is something that we as clinicians, I think, would, could benefit from, and that our patients would benefit from. And I do strongly believe that all physicians are interested in trying to provide the best care and to be the best clinicians that they can. And so I think that a big part is we need to train our intuition for diagnosis. And we need to do that with practice, and think of it like a foreign language. When I talked about, adjusting these probabilities, like doing a 2x2 table once in medical school really isn't going to help you in rapid clinical practice. We need to make this more automatic and calibrated, more system 1 than system 2 type thinking. Right. And, if you're trying to learn a foreign language, like if you're trying to conjugate verbs in Spanish, you can do it and you can learn how to do it, but you have to do it so quickly that you stop thinking about it, so you can actually form sentences and actually form, thoughts and express those to people. So we need to stop thinking about this as a math problem with exact answers, but it's more of a gestalt. And this is really, I think, the failure of evidence-based medicine, that we haven't been great at implementing it, especially for testing. And so some of the approaches that we've been working on and that are still in progress. So, I show this as more of just an idea. And I just talked to one of the IT people about it working. So, bear with me if this doesn't work. But so we've been working on trying to create a game that people could use to train their intuition around probability. And so where people could go and play, and you can do some settings adjustments, but I won't go into that. And then you get a question. And so it started out with like, okay, the patient has a 15% pretest probability, say for COVID-19, based upon fever, cough, and lives with someone who's COVID positive. The medical test, this is a PCR, has about a 90% sensitivity and 99% specificity. So a negative test means what? Well, okay, I'm running out of time here. I've only got 30 seconds. So I'm going to guess like at 2%. All right. I've done this a few times. But a negative result still means there's a relative chance that they can have COVID. And here's how a better way to think about it in the 2x2 table. This idea of natural frequencies, Gerd Gigerenzer, a psychologist in Berlin, has worked a lot on this. And then it's like, if you start out with 100 people, 15 of them are positive, 85 are well, and you can look at the number of true positives and false positives to get, what the estimate is. And I would say, don't look too hard at this. I was on the phone with them last night, and we need to update this. But the general idea of the natural frequencies is one that's been advocated as a better way to learn this. And so if you had a game, say we're going to have 10 questions, and you can go through and you can get scores for how fast you do this. And so there's a positive C. diff PCR means what chance of C. diff infection. And you can run through this for a lot, and you start to get a natural approach to doing this kind of thing. The other thing I would argue is decision support could be helpful. Let's see, and let me just exit out of this so I don't get any pop-ups. So this is one we've been working on Testingwisely, and this is for COVID-19. And we've been trying to do this for other tests, just to really make it easier for clinicians to think through this, and probably not like in the middle of seeing a patient, but to work on calibrating their answers. And I do think if electronic health records were really built to best improve patient care, this type of thing could be built into EHRs. So this is one we did for COVID-19. And we actually have the rates in your county. So I selected Chesterfield County, which I hope is where Richmond is. I did a quick look on Google this morning. And you can see that the 7-day cumulative rate is 0.26%. That means that roughly 1 in 400 people had a positive test in the in the past 7 days. So we're using this as kind of like, what is the incidence of COVID? This step number 2 had a lot of information in it that the programmers, I think, made disappear recently, but where you can click through and increase your exposure risk by things like, do you live with someone who has COVID? Have you been, do you have different symptoms that would go along with COVID? And then you can choose the test that you want to use. And so these are the main tests that are out there. Standard PCR, a rapid NAT test, which I haven't seen much anymore, but was one of the rapid tests, and then antigen tests. And so you can see, like, say we're looking at the average person. This is like, say, if you're doing pre-procedural testing, you're looking at someone who has average risk, and you get a PCR test on them that's positive. Well, how likely do they actually have COVID with that positive result? And the truth is probably only about 19% of the time. And you can actually try to, there's some data around about how likely are they to be contagious with a positive test. And you can see even much less likely. And this is because we have this problem with clinical false positives for PCR, and that's people with the residual RNA who had a previous infection, be it symptomatic or asymptomatic, and can have a positive test for a long time after that. Similarly, if you wanted to say, well, say this is someone who is high risk, like say 50% risk. And let's see, sorry, technical glitch. So 50% pretest risk, and you were trying to rule them out. You say you had an antigen test, and you say, like, if the test is negative, well, they still have a reasonable likelihood of having COVID, even though they're much less likely to be contagious. Which is often what we're really trying to do with an antigen test, more than really know if they truly have a COVID-related syndrome. So this idea can be used for a lot of tests and much more easily for other conditions outside of COVID. But I hold this up as an example. Oh, and you can see, I think the programmer has updated it. So you can see that you can increase these things based upon, and this is the best evidence from the literature in terms of the likelihood ratios associated with these things. So showing that as an example, and let me just get back to the talk, but I do think that there's room for improving and making it easier to actually use probability in medicine. So to summarize testing, I think a few tests are great. And so, like, say an HIV test is one of these tests that works almost like magic. It tends to be so accurate, like, almost 100% sensitive and specific, that even if you test people with a 1% pretest risk, a positive result means you're almost certain to have HIV. So that's kind of amazing. And that's how we think about tests. But really, most tests are mediocre. So say a stress ECG is actually only 60% sensitive and 75% specific. So that means you test them with a 1% pretest probability. A positive result makes you get a 2.4%. So it just really doesn't mean much. But many tests are useful if used right. So this is a D-dimer for PE. It's 97% sensitive, 40% specific. And say if you had a 5% chance of PE, which is a moderate risk, a negative D-dimer really is helpful in ruling that out. And a simple, low-cost, easy test can be very helpful in actually discharging somebody. But all tests are dependent on pretest probability. And highlighting mammograms, these are the numbers which actually are a little bit better, more positive leaning than reality. But I show them just to illustrate this point that, say, for a 45-year-old woman who has a 1-year incidence of breast cancer of about 0.15%, that's their pretest probability because they're asymptomatic screening. A positive mammogram means they have about a 3% chance of breast cancer. So it doesn't go up much. And even for women who are 55, so in that age range where it's recommended, a positive test means you go to about 5% chance. Whereas, like, if there's a palpable nodule, if someone found something that was identifiable, the pretest risk is much higher, and then mammograms start working really quite well as a diagnostic test, not a screening test. So more about testing. This is an op-ed I wrote a few years ago that I would refer people to. And testingwisely.com, we are working hard to have new tools and animations up. It's just a limitation of technology. So treatment, I would argue, is very similar. So modern medicine, we have diagnosis and treatment. And in treatment, we have what is the probability of outcomes without doing anything. And then if we treat, we try to change that probability. And we can understand the probability of harms and benefits. So we asked clinicians about this. We had what we thought was a bread and butter case, a 62-year-old man with well-controlled hypertension on aspirin with new atrial fibrillation. He wants to know if he should start an anticoagulant. And we asked, what would you tell Mr. Miller, this one person in front of you, is the chance that warfarin will prevent him from having a stroke in the next year? And this is, a question of like, well, if you looked at 100 people like Mr. Miller with atrial fibrillation, how many would have a stroke in the next year? And so this is if you do nothing. And then the question is, how much do they benefit from taking warfarin or another anticoagulant? And there's different ways of looking at this. I think the way that pharma often encourages is like, well, if you don't have a bleed, then you benefit from treatment. So that would be 98% of people benefit because 2% of people will have a bleed. Or if you use relative risk reduction, you'd say, well, it's about a 50% relative risk reduction, so about half of the people benefit. But really, the way that shared decision-making guidelines advocate, and really what evidence-based medicine would advocate, is that, well, there's one person who's going to have a stroke out of 100 like him, so only one person can benefit, right? And so, essentially, this is like, you're placing your bets to try to hope for a good outcome, but only 1 in 100 will have this outcome regardless. And so it's probably about a 1% chance of benefit, and that's the absolute risk reduction. And so when we asked people, we found a pretty strong overestimate. So you can see in green, this is the absolute risk reduction for a patient like him, and it's about 1% or less. The relative risk reduction is in lavender here. The median answer was 50%. So they said he has a 50% chance of benefiting in terms of preventing a stroke in the next year, but there's perfectly, a perfect distribution of answers from 0 to 100%. And for this question, we ask, well, in patients like this, in your practice, how often do you treat them with warfarin? And what this graph shows is that if people estimated the benefit was less than 15% from warfarin, well, they were much less likely to give warfarin. They only gave it to about 10% of their patients. Whereas if you estimated the median number, which is 50%, you would give it to about 75% of your patients. So that would mean that you give almost everyone treatment versus you only give 10% of people treatment. So I'd argue that this understanding of probability matters. And so that'd be the difference between saying, Mr. Miller, you have a 50% chance this medication will prevent a stroke in the next year, to saying you have a 1% chance this medication will prevent a stroke in the next year. And these should prompt very different decisions, I would think, in most clinicians and patients. And I treat 75% of similar patients in my practice with saying I treat 10% of similar patients in my practice, which is a huge difference. I think probably the best example of probability use in medicine is actually from cardiologists, the ASCVD calculator, which I think is great, and I would encourage people to use, although I understand the limitations in implementing this, I think related to just the paradigm of probability versus a more kind of simple cookie cutter, yes or no, do it, and not like, well, there's a chance and you modify that chance. So this appreciation of small effects led to precision medicine, the theory, which has largely not been proven, but for a lot of treatments, we're treating a lot of people to get benefit in one person. And how do we talk about this if we accept probability? Well, I'd argue we need to stop saying risk versus benefits. We need to say chance of harms and chance of benefits, because that's actually scientifically what we're talking about. That's what clinical trials monitor. And saying to somebody like Mr. Miller, it's like out of 100 people like you, 1 will develop a stroke with no treatment. With treatment, 0 to 1 out of 100 will develop a stroke, but 1 out of 100 more will develop serious bleeding. And this is why guidelines would actually say don't treat somebody like him, even though most people would treat. This is an example from COVID that I won't run through, but it was just that Stephen Hahn, the FDA commissioner, said that plasma for COVID had a 35% chance of reducing death in people. So it's remarkable. And truthfully, the absolute risk reduction was 3%. So he was criticized a lot. But then later randomized controlled trials, when they finally came out, showed there was no benefit of plasma. So I do think that, this is a real issue that we could all be better trained to address. And I wrote about this in an op-ed, if people want to read about that more. So I'd say if you're feeling down about medicine, which I do think is one conclusion to this talk, I'd say I love taking care of people, and it's disappointing to learn that diagnoses and treatments aren't so key as taking time and concern. But the good doctor really is not like House MD, which is too bad, because it's kind of godlike and sexy, and as long as you get the right answer with your big brain, it doesn't matter if you're like addicted to narcotics or whatever else. But really, it's more like being Mr. Rogers, where you're spending time with patients, accepting uncertainty, making decisions, and trying to find the best way to proceed without being too cavalier or too risk adverse. And in the big picture, we overestimate chance of disease 2 to 10-fold. We overestimate benefits of treatment many-fold. And this changes how we treat patients. And each of us repeats these basic decisions many times a day. And if we think about a hospital or a system, then that starts to really turn into big numbers. And this probably contributes to the up to 1/3 of medical care that's known to be medical overuse. And I think if we could be more scientific and work on our own behavior as clinicians, we could create a more scientific, sustainable, humane, and equitable system. And if we use probability, we could better understand cause and effect, have more time evaluating patients with fewer tests, have fewer but more meaningful diagnoses, and prioritize treatment with large benefits, things like HIV medications, PCI for acute myocardial infarction, certain types of chemotherapy, over the marginal medicine that takes up a lot of our time, treating mild hypertension, low-value cancer screening, et cetera. And with this, I'll stop. Thanks for your time and attention, and I'd be happy to talk with people either in Q&A or later by email. I'm not in any rush to get off.
Dr. Morgan, that was excellent. Thank you so much for that very academic and engaging presentation. And you did it in a masterful fashion in a time crunch, which is even more impressive, finishing on time. So the first thing I'll ask is for Thomas to please keep the link live for a couple more minutes for those who want to stick around for a Q&A. We'll take a look at the chat here and see what we have. I think from Dr. Gupta, the first one here is, what kind of data exists about comparisons of excessive harmful testing in academic institutions versus non-teaching community institutions? In other words, I think, are we better or worse than our peers in the community?
That's a good question, and I'm probably not the best person to answer it. I mean, I think that certainly academic institutions don't tend to fare better, and I think if anything, probably tend to do a bit more than community hospitals. But I think what's been more profound, and it's really interesting as an individual who hasn't traveled around the country working in different places, it's just the regional variation, which is quite real. And so like this picture here, this map is from the Dartmouth Health Atlas, where they looked at utilization of imaging tests. And the red areas are where they have up to 2 or 3-fold higher use of imaging. And it's just quite remarkable to see that certain parts of the country do things very differently than other parts, and yet they don't see differences in outcomes. So, and this is like Atul Gawande had this New Yorker piece from probably 10, 15 years ago, where he traveled to McAllen, Texas. And, and said, I was just trying to explore why people practice differently. And that was one of the reddest places there was where they did the most overtreatment. And it's clear that there's very big cultural differences that tend to predominate both at institutions and certainly in regional areas.
That's a great point. I believe in the book Overtreated by Shannon Brown-Lee, she covers that and refers to the scientist at Dartmouth University who's doing that kind of that research on really the regional differences in test utilizations and treatments. Very cool. So follow up again from Dr. Gupta, Gaurav Gupta, is one way that we have one way that has been proposed to reduce testing is to show the provider the cost of a certain test. Has that been empirically tested or proven, Dr. Morgan?
So that's a great thing, and I'm glad that you bring it up. That there's been this idea that if people understand the cost, then they wouldn't do it as much. And I do think it's interesting to look at. But I think most of it, and largely, it hasn't been found to have an effect. And I think that's largely, who's the cost to? Does the patient have to pay it out of pocket, which is probably what most of us doctors care about. And, I think very few of us care about this system and trying to, potentially do something that's not ideal for your patient to save the system money. I think none of us want to be that clinician. And so I think that, showing cost hasn't really worked out very well. And then if the other downside is that actually like knowing what the cost is, and especially the cost to the patient, feels almost impossible as a clinician.
Yeah, that's absolutely true. Sometimes the costs are so difficult to really ascertain. To follow up on that, sir, what about the concept of peer-to-peer comparisons? Now, it may not necessarily involve a cost, but a peer-to-peer across a hospice service or even across an ID division. This is a frequency with which you order these tests compared to peers. What are your thoughts on that, and what sort of data exists to support that as a risk reduction or a reduction mechanism?
Yeah, I mean, so that's a great point. And I do think that's one of the, somewhat using administrative data type approaches that can be used. And you do see a great variation between people within a clinic, within a system. And, and there has been, there was a study where they looked at antibiotic use for people with, with non-bacterial respiratory disease, and found that being compared to your peers, often with like a graph that would say like, Dr. Morgan, you are here, and here's where all your peers are, tends to drive people more towards the median. The people who overtreat, say, for viral sinusitis will tend to decrease with that. But it is a pretty labor intensive approach because, it often involved a fair amount of education as well as showing this information to people. So I think it is a worthwhile one, but I think it is kind of like the idea of saying that like, there are these like little problems and we can address these teeny problems of overuse and unnecessary care versus like, well, conceptually, we need to accept that we tend to do a lot of things that don't have benefit, and maybe, just be a little bit more skeptical about, what has true value to our patients to what, really has very marginal or no value.
Great point. And the thought of driving something down towards the median across a group of providers sounds great, assuming that the median is the right thing to do. That may not be necessarily proven. So let me follow up on a comment you made. You talked about the magic test hypothesis and talked about various ways to approach it. If you had systematically had to tackle the magic test hypothesis such that it's debunked, or at least taught more appropriately across undergraduate or medical school residencies and fellowships, what would you propose in terms of curriculum, and with what frequency would trainees or learners need to be exposed to that?
Oh, great question. This type of thing I sort of, mull over in my head when I'm like halfway awake in bed. And I think that there'd be a lot of room for this. Some of the questions we ask doctors about probability, where it's, how likely is this test, they to have a disease with a positive test? That type of thing has been asked, and the math is pretty simple. And I heard about like high school students or college students somewhere being asked that as like one of their exam questions. And I do think that there's a lot of room for improving basic, kind of real life probability in, even high school, but certainly college. And, if you think about what are the pre-med courses that people take, there's a lot of useless courses, right? Calculus was one I took that had no bearing on medicine. Organic chemistry, it's kind of hard to know what value that had also. So I think that there's room, and I do think, basic probability would not be that hard. And that really is a lot of the math of clinical care. And I do think that, trying to get this impacted at a kind of an early level is the way that you actually change people's beliefs. It just takes a long time to see that effect.
It's really a cultural shift. I like your ideas of kind of going more upstream in the educational process before even medical school to tackle some of these issues. I also like the concept of exploring potentially useless courses that are required for going to medical school. Maybe that could be a grand round discussion at some other time. All right, does anyone have any additional questions in the chat? I don't see any in the chat. Dr. Morgan, are there any comments you'd like to close with? At this time, sir.
No, I certainly would be happy to hear people's thoughts. If you want to email me, I think my email is pretty available, on the web or otherwise. And thanks for your time. And, I do think, clinicians really need to be the leaders in how we, continue to revise and improve medicine. And I think if clinicians are interested in probability, even if there's not immediate answers to how to change things between the metrics and the time demands, I think eventually we will figure out better ways to change the way we do medicine.
It would be wonderful for us to be able to translate this into a call to action, not only across medical schools, but really all medical practitioners. Really wonderful presentation, masterful as always, academic with references. We really appreciate it. And I apologize again for the slightly late start due to technical issues, but you finished on time beautifully. Thank you, everyone. It's been an absolute pleasure. And I believe this will be available on recording and a link that will be shared later. Thank you.
All right,
Bye-bye.
thank you.